Good evening, everyone, and welcome to the North Reading Republican Town Committee 2018 Questions Forum. First, I would like everyone to rise for the Pledge of Allegiance by the Girl Scouts of North Reading.
Girl Scouts, attention. Girl Scouts, advance. Please join me in the Pledge of Allegiance. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Girl Scouts, dismissed.
Thank you very much to the Girl Scouts of North Reading. I think they deserve a wonderful applause for what they've done. The Girl Scouts of America is led by parents who look to raise their children to become our future leaders of our country. So thank you. You may be seated. Just to let you know that the event tonight will be live streamed on the North Reading Republican Town Committee Facebook page. It'll also be recorded by NORCAM for future broadcasting before Election Day. And it'll also be recorded by Janet, your last name again, Janet?
Aldrich?
Aldrich from
Hamilton,
Massachusetts, and it'll be on the cable access there as well. We reached out to all the possible venues. All the TV stations were notified of this event, and all of the major newspapers were notified, as was the North Reading Transcript and its affiliate papers. The purpose of this event is to be informative. It's an opportunity for many to listen, to possibly hear something they didn't hear before, to help them make a decision. It is not the purpose of this event is to take a side or give a specific perspective. We have speakers for that, and we have wonderful speakers for that, as you can see. I want to thank the members of the North Reading Republican Town Committee for helping pull this together, and I definitely want to thank Kitty's for making available this really nice room. They've done a fantastic job here, and so Debbie Berkmeyer and Scott have been very gracious. So I think we should give them a hand as well. Okay. So we will progress as follows. Each question will be 30 minutes. 10 minutes for the yes speaker, 10 minutes for the no speaker, and if there are any questions, there'll be 10 minutes available for Q&A. And we will try to do that, one for the yes, one for the no, but that will be all determined by how much time is available to do that. So the first question is patient to nurse limits. To limit the number of patients assigned to each registered nurse in hospitals and certain other healthcare facilities. We took this information off of the voter flyer that was, or booklet that was sent by Bill Galvin to everybody, so we try to stick as close to that as we possibly can. The yes speaker is Roland Goff, and he represents the SafePatientsLimits.org. So if you please give him a hand.
Okay. All right. Well, good evening, and thanks for inviting us out here to talk to you about number one. The question, obviously, you've probably seen and heard a lot of it already, so I'll just do kind of a quick run through and talk about how we got to this point of being on the ballot in a few points, and obviously we can open up to questions. So, question one would establish nurse-to-patient limits in each unit except for the ICU in Massachusetts. We already have a law in Massachusetts that sets a limit in the ICU. That was done about 4 years ago. We're now trying to expand that out to every unit in the acute care hospital setting. We believe that more nurses equals better care. And there are going to be studies that you can see on our website. There's a whole list. If you go to our website and look under the tab, the evidence, you'll see. And a lot of the studies will confirm that more nursing care is better for patients. So you'll see that with each additional nurse, there'll be about a 17% reduction in complications. Also, Massachusetts right now ranks almost last in readmissions among the 50 states. We believe if this law is implemented, we can cut down on readmissions, which is better patient care, and will also cut costs. So when we look across the state of Massachusetts, we see a variety of things. We see places in Boston, if you go to Mass General, or you go to Brigham, are you likely to get the nursing care that we speak of in question one? On most cases, yes. But you're not going to get that same benefit in certain hospitals across the state, but you're still paying the same premium. You're still hoping to get the same care, but you're getting different care because there's no standard across the state. We don't believe that's the best way to deliver care to the Commonwealth residents. The second thing, this has been about a 20-year struggle. The nurses have proposed a law at the state legislature for about 20 years to establish these limits. The only breakthrough was a few years ago when the legislature agreed to institute this in the ICU. We believe that's been a success. We believe it's improved care in the intensive care units, and we believe that by moving it out to the other units, you and your loved ones will get better care. The other thing is, you should know, is there's only one other state that has limits, and that's California. We believe the California experiment and experience shows that these limits work and that they're beneficial for everyone in the state. Also, cost is an issue, and I think you've probably read a lot, and the HPC came out with some estimates, and you've seen a lot of cost estimates. I think a lot of those cost estimates are inflated, but it still only amounts to about 1% of the revenue of the hospitals in Massachusetts. So I guess when I look out there, if I was going to be a patient in my local hospital, I would like to see my local hospital add 2% to cost to make sure I have better care. So those are really the kind of big things. We believe that it'll make better care. We believe California has proven that these limits work. We also believe the ICU law in the state of Massachusetts proves that limits will work. We also believe, although there will be a cost, that it will not be sufficient, or not be at a level that will have effects services or hospitals in Massachusetts. In California, there were no closures after they passed their law establishing these limits. We do not believe that there should be any closures here when yes on one becomes the law. Thank you.
Thank you very much, Roland. Up next for the no speaker is Kim Stevenson. She represents the ProtectPatientSafety.com. She's a research manager at the Massachusetts Health and Hospital Association. Thank you.
Hi, thank you for having me. So I just want to talk, I'll try to go through the same list as Roland. Yes, as Roland went up there. So first and foremost, the MNA who's brought this question forward has tried to position this as a bedside nurses versus executives fight. And I just want to point out that that's absolutely not the case. WVUR recently put out a poll in which nurses were pretty much evenly split on this. And even looking at members of the MNA, 33% of MNA members who were polled are opposed to this question. So that's the group bringing it forward. They don't even have unanimous support among their own members. Only 15% of nurses think that a ballot question is the way to handle this. 15, 1-5, not 5-0. So I just want to put that out there right now. The reason why we're opposed to this question is not because we don't like nurses or that we don't believe that nurses provide excellent patient care. Nurses absolutely provide excellent patient care, and of course more nurses is better. The problem is with the rigidity of these ratios that would be applied to every single hospital across the state in the same manner, when every hospital in the state does not provide for the same type of patients, the same clinical problems, they don't have the same nurses and the same facilities, technology, resources, etc. So for example, Boston Medical Center is one of the biggest trauma centers in New England. They see very complex cases, a lot of sick patients versus, for example, Haywood Hospital out in Gardner, or Athol Community Hospital, or Nantucket. A lot of these community hospitals, they send their more critical patients to the academic medical centers because they have the skills, the expertise, and the resources to be able to provide the elevated level of care that's required. So no two patients are the same, no two nurses are the same, no two hospitals are the same. So why we would try and staff every single hospital the same, it just doesn't make any sense. The bigger issue is that for complying with this law, there's really only two ways to come into compliance. Because these ratios would be very strict, it would be at all times, which means 24 hours a day, 7 days a week, 365 days a year. So that means you have the same staffing levels at 2 a.m. as 2 p.m., even though there's no testing going on at night or no procedures other than maybe emergency stuff. So the level of care is not necessarily the same, particularly for stable patients, as in the middle of the night when patients are sleeping, as it is during the middle of the day when they're getting testing and procedures and therapies, etc. So to comply with the ratios, you either have to staff up your levels and hire however many more nurses in your facility to meet this at all times mandate, which is more than just looking at averages, or you have to decrease the number of patients that you see. Because every time a hospital violates one of these ratios, they can be fined up to $25,000 per incident per day. And as you can imagine, these fees can rack up pretty quickly. So what we're most concerned about is that there aren't enough nurses to be able to comply with the ratios and meet current patient demand at all hospitals in the state. And also that even if there were enough nurses, some hospitals, just because of their payer mix, that are more reliant on public payers that don't reimburse at the same rates as the private payers, so like Blue Cross Blue Shield, for example, versus Medicare or Medicaid. Hospitals would have to cut services, programs, other staff member types, other members of the care team. And care really is provided by a team. Nurses are not the only ones providing care at the bedside. You have respiratory therapists, you have pharmacists, you have nursing aides, licensed practical nurses, physicians, residents, etc. So it's not just nurses. So the Health Policy Commission, which is an independent body, independent state agency, estimated that the cost for this would be upwards of $950 million per year across the state. And they also said that this was a conservative estimate because they were not able to account for emergency department nursing increases and also other costs associated with outpatient units, observation units, and the initial implementation of the acuity tool. So the Massachusetts Association of Health Plans has already said, based on the HPC analysis, that insurance premiums would likely rise because it's likely, as we saw in California, which I'll get to in a moment, that hospitals will have to go, they can't negotiate with Medicare and Medicaid, but they can negotiate with the private payers, and they said it's likely that hospitals will try to renegotiate payment with the private payers, and that these costs would likely get passed on to consumers. So California is not a model to emulate. There are some significant differences between the two laws I'll get to in a moment. But first of all, there's been over a dozen studies on California. I've read them all. I've read all 73 studies on the M&A's website, and I've read about 200 others on top of those, or maybe more. So I've done my research on the research. The Health Policy Commission hired Joanne Spetz, who's a researcher from the University of California, to speak, and she participated in their study, their analysis. She has studied California since the beginning. She's studied it more than any other researcher in the country. And she concluded that there were no systematic improvements to patient outcomes in California, but there were increases in costs and financial implications on hospitals. So in the research, we see everything that we've been stating. Longer, increased ED wait times for emergency departments, holding the wall. If you Google holding the wall California, you will see all the things that we're talking about, publications, blogs, etc. On this phenomenon where paramedics they're just waiting on the sidelines for nurses to be able to have a patient discharged so that they can take on another patient. Other things that we saw were disproportionate effects between safety net hospitals, those that provide care for the most vulnerable patients in the state, and other non-safety net hospitals. Even Linda Aiken and Matthew McHugh, who the M&A cite very frequently, they did a 2012 study on this, and they found that not only did safety net hospitals have lower staffing levels before ratios were implemented in California than the non-safety net hospitals, but this trend continued after ratios were implemented. They had lower rates of compliance, and they found that through wage inflation for nurse salaries, the safety net hospitals actually lost a lot of their good nurses to the non-safety net hospitals because they weren't able to pay as much. So nurses left the lower paying hospitals to the higher paying hospitals. There's some key differences between California and Massachusetts with the law and the ballot proposal. California had 5 years to implement their ratios. Their law was passed in 1999. Ratios did not go into effect until 2004. And even at that point, it was a phased-in approach where they had a starting ratio in 2004, and then it increased in 2005 and 2006, and finally in 2008. They also allow the ratios to be met up to 50% by licensed practical or vocational nurses. The M&A's ballot requires the ratios to be met exclusively by registered nurses. California also allowed hospital waivers for small and rural hospitals. The M&A's ballot explicitly forbids any such waivers for any reason. And that's in the ballot. I've got copies. You're welcome to take a copy of the ballot before you leave. Other key differences, California does not have penalties, so the hospitals that are not in compliance are not getting fined, upwards of $25,000 per day, like hospitals here would. And finally, just the support for